Hello, I'm Dr. Lynne Reid, and today I've got with me one of my really fabulous and close friends, Dr. Alice Chang, who is a consultant psychiatrist, and we are covering today the really interesting and emerging topic of ADHD diagnosis in women in particular, and just the difficulties perhaps in identifying it and looking for those key characteristics that perhaps often get missed. So I'm just going to ask Alice to tell us a little bit about herself. And if she doesn't fill in the gaps enough, I'll just pick her up on her behalf. So Alice, tell us a little bit about where you are at the moment and what do you do in practice?
I'm a psychiatrist based in Cairns, and so I have dual qualifications as a general adult psychiatrist as well as child medicine psychiatry. So in my private practice, I see women and children and adults through their lifespan. So that's why today's topic is very close to my heart, because I see not just adult and women with ADHD, but also seeing them as the children who have never been diagnosed or overlooked during their educational or developmental trajectory.
Awesome. And you didn't big yourself up at all there, but Alice is heavily involved in the Royal College of Psychiatrists. She does some fantastic work with trauma patients also. And I know that she's previously, and I know this because my daughter has attended the same school as Alice. So she was twice over the Young Queenslander of the Year for her work in sort of charitable organisations. Quite a phenomenal backstory. However, today we're talking about ADHD. And for me, I find this really interesting because as a female GP, I get lots and lots of women presenting where ADHD hasn't been on the script for me, but it evolves over time and knowing patients. And these patients to me will often be things like my patients with binge eating disorders or my ladies with intractable anxiety. And often, again, those professional ladies who present very burnt out, spinning lots of plates. From your point of view, where do you see ADHD and why do you think these women are coming and presenting as other pathologies? What do you think has happened in their trajectory, as you see?
I think you're absolutely right. We're definitely seeing an influx of women in their late 30s, 40s, where they are starting to get really burnt out in their career because they are reaching a pinnacle in their professional lives. They usually have children, responsibilities in the household, and all these stresses come together, make them not have the coping mechanisms that they used to have that did very well for them in their 20s and 30s. So what you're seeing is a comorbidity of presentation anxiety. You're seeing the binge eating because that's what they use as a sort of self-soothing at the end of the day, stress relief. And then what is also interesting is that we know that there's quite a lot of intersection between ADHD, anxiety, bipolar affective disorder, and then also neurodivergence. So women who are very high functioning but have neurodivergent traits as well. So when the stresses hit, those cracks are starting to show, and that's when they start to question themselves. Is there a pathology underlying this? Is there something going on? And what is very interesting is they're presenting as all this and not ADHD, because usually it's the anxiety that starts to show. It's the weight the weight gain or the binge eating that starts to become a problem in their lives. And so that's when they probably start to present to you, go, what's going on in my life?
Yeah, and if I look over the last sort of 10 years in general practice, the amount of women I see with real awful diet trauma. So there'll be women who are very busy, they're spinning lots of plates, they're seeing lots of challenges, they've got kids, they've got a profession now, they've maybe got care responsibilities with parents, and they're on the PNF and everything that they're doing. And they come to me because the weight is just going on and on. And when you take down what are your barriers or what do you think are your triggers with your weight, they'll often refer to things like after birth, I gained a bit of weight, but then life got really busy and I found I was snacking. And they will tell a lovely story of having a really busy day, rush. They've got the kids off to school, they've gone to work, they haven't stopped for lunch, they're jumping in the car to go and pick the kids up from school. and they'll stop at a petrol station and grab something to eat. And invariably, petrol stations don't have anything healthy in them. So they'll grab highly processed carbohydrate food and they'll eat it, and then they'll feel this real, and I also say to them that it's this dopamine response. They get this lovely reward and relaxation, but they are self-medicating that sort of crazy busy that they're taking on. For women that are maybe developing other strategies, and I'm talking about things like binge eating, I'm also looking at how they are managing their lives. At what point do you think is life just very busy? And is what point in life that you think actually the way that you're managing it is a bit more pathological than just a busy life? There's something else underlying. What are the key things that me as a GP or my patients, my female patients, should be looking out for?
I think the way we should be looking at a lot of the mental health concerns, it should be looked at in terms of spectrum. So ADHD or any other diseases should have a spectrum kind of approach to it. So it's usually when there's normal, understandable life stresses, but then when that crosses over into maladaptive coping mechanisms such as overeating, or you start to overcompensate with lots of lists, or you're just actually feeling physically that not anxiety, or you're starting to find that you're not able to cope with the cognitive demand that's happening, you're becoming very forgetful. So when stress and just normal stress shifts into impairment, whereby you're finding you're spending a lot of your day engaging in these unhelpful coping mechanisms like binge eating, snacks and what have you, or when you just feel like you're really burnt out and you've got nothing at the end of the day. And then if that's prolonged, usually after a month or even extending to 6 months, that's when you really need to start to be alert to its impact.
I think what I've noticed with some patients that I have is the joke and the reference of no wonder mummy drinks. Mummy's having a glass of wine. And again, those are my patients who are very busy. They're spinning lots of plates and they come home. They're then doing dinner. Then they're doing the clear up. They're getting they're having a glass of wine, 2 glasses of wine of an evening. And I see them because they want to improve their health behaviors. And it's not until you unpick maybe some of the symptoms of that undiagnosed underlying issue that you see that they are again self-medicating with food or with alcohol. Some other mechanisms I've seen patients using is shopping, like shopping online. And it's interesting when we remove using sort of weight loss strategies, or if they're using the GLP-1s now that are huge, without that reward from food, they're looking for that other dopamine hit from something else. And again, so then it becomes, that to me rings a bell. I think, okay, so we thought the problem was your appetite. We thought the problem was your relationship with food. And we've removed that relationship with food, but there's still some other, you're seeking that relaxation, you're seeking that downtime from something else. And as I say, I've seen it with patients who successfully lose lots of weight, but have taken up online shopping. And it's quite stark when you see that. That's an aside. But if we're to look at, for example, a 36-year-old woman, and she's coming to me as a GP, she's tired, she's busy, she's anxious, what are the questions I want to be asking her about her behaviors or habits that will help me elicit, is this an underlying anxiety or is this an undiagnosed ADHD? What kind of questions should I be asking her?
I think you probably have said absolutely correctly, looking at the primary symptoms. What are the symptoms of anxiety? What are the symptoms of low mood? Or sometimes that comes out as exhaustion and burnout. And then you look at other domains, such as their functional domains. What are they doing to cope, using coping strategies, eating, alcohol, shopping, all sorts of stuff that they can do. And then also whether they've actually had any time to engage in positive activities, time for that, socialization, eating well, exercise, all of that. If all of those comes back as the picture of someone who's probably quite anxious and probably quite burnt out with a lot of negative coping strategies, then I think definitely first and foremost, I like your idea of that onion layer. You strip off, you treat one thing at a time because that's all you can see before we jump into the ADHD. It's a good idea. Maybe start looking at adjusting those behaviors and removing some of those barriers and treating the anxiety and mood. And then if there is still leftover extreme sort of inattention, poor memory issues with, I find a lot of maybe their eating issue is to do with they just don't have very good body cues. So rather than this is just a coping mechanism, a lot of them will say, I've never felt hungry at the right time. I've always used eating as a mechanism for dopamine hits or relaxation. So they've never really felt hungry for that.
I recognize that so much. And I've got two amazing patients that have gone through the ADHD diagnosis process. One actually teenage boy and one being an adult female. The teenage boy, again, after his treatment, amazing, was saying to his mum, I remember eating when I wasn't hungry and I didn't know why I was eating. And he had lots of problems with his weight and things, but that has evolved now. He's got a healthy relationship with food. He knows when he's hungry. He eats when he's hungry. And he's aware of that big shift. I've got this other amazing patient who's done brilliantly again. And she's someone who had a lot of diet trauma. She went through life trying and failing with diets for a long time, then did a really intense sort of shake-up of her well-being, huge amounts of exercise. She went really hard with restricted eating. And she got the weight loss that she did. She lost 15 kilos in weight, but she was really punishing herself to do it, to achieve it. And then when she achieved it, she couldn't maintain it because the underlying drive for her to eat was still there. She's had a diagnosis of ADHD just 3 months ago. And speaking to her now, it is night and day. She's so happy with her relationship with food now, where she knows that she is not seeking comfort in food. She's not eating mindlessly. She's eating when she's hungry. I can see I see the positives as well. I really see the good news stories as well. I do want to ask, because amongst colleagues and the general population and the media and in my work with universities and the students, there is sometimes a sense of, are we over-diagnosing? Is everyone now getting this diagnosis of ADHD? What's your take on that? Are we over-diagnosing it? Are we under-diagnosing it? Are we getting it just right? What do you think is the real picture of ADHD and how it sits in terms of its likelihood within our general population?
Look, I think ADHD, again, is a spectrum, and often in psychiatry or child psychiatry will say there are people who have ADHD but doesn't fulfill the criteria, and there are people who fulfill the criteria but doesn't need treatment for ADHD. So I think if we look at it from that perspective and go back to that sort of onion layer by looking at the comorbidities and the goal is not to diagnose ADHD, but rather to look at optimizing your health and being. And ADHD may be one of the tools, will be a really good way of starting point. And I actually think because there's so much knowledge out there, everyone, is very receptive to perhaps, entertain the idea of ADHD. I actually think it's not a bad thing to use that as an inroad for people to start to take care of their health and to start to question, why am I feeling this way and can it be different? And then, they approach their GP or even get a referral to see a psychiatrist. That will be a really good way to then do a stock take of their health and mental health and start with that. And I guess back to your question, are we overdiagnosing it? Particularly in the general population, it's difficult to know whether we are or we're not, because it really is at the hands of the prescriber and the person who diagnoses them. But I think if you don't ask, you don't get. And a lot of women have spent their life masking, and maybe it's a factor that it now come into the limelight. So a lot of people with pre-existing conditions who didn't speak up about their conditions and just thought, I'm just this way or there's no help for it. Maybe there's a rise of that. It's really hard to know in general population what is the true number of ADHD, particularly if you look at ADHD as a comorbidity to lots of other things as well. So as I said, you could have symptoms of ADHD, but not fulfill the criteria because you may have a variant of bipolar affective disorder, and that may look like ADHD. So I think it's more important to look at optimizing your health and rule out these other things that may be a barrier to your health. And then at the core of it, say, well, is the lasting ADHD, and then have a trial of, the treatment for it.
I had a really interesting conversation with a retired pediatrician. And again, I thought this conversation that I was going into would have been him being relatively dismissive about the new surge in diagnoses of ADHD. And he wasn't. He was so wise, and he sat back and he said, look, like you say, it's a spectrum. And he says, if you look at it and compare it to, say, asthma, again, it's a spectrum. You'll have people who have got brittle asthma that need a lot of input. You'll have people who have seasonal, or actually their asthma is less problematic as they age. However, with asthma, if you take them out of the environment, say, of living in the Highlands of Scotland, I'm going to say that because Highlands of Scotland are beautiful and clean and less pollution. If you have an asthmatic who's living in the Highlands of Scotland and their asthma is relatively well controlled, and you take them to Delhi, where on that particular day the air pollution is really bad, their asthma will play up. And he's put it to me like this: if you take a patient with ADHD, if you take a patient with ADHD who perhaps does a fairly straightforward, fun job, works 28 hours, has great social connections, loves to run, swims for peace of mind, and has a balanced, supportive life, their response or their requirement for treatment is probably going to be less than you take someone who their ADHD is perhaps up the scale a bit more, just like their asthma might be up the scale a bit more, and you put them into an environment that is emails every 5 minutes, their boss is at them for deadlines, they've got 3 kids, one of which has got a million sports that they've got to get to, so their diary is full with that. They've got needy, independent family members. They've got their phone pinging all the time. That environment is different to our Highlands, Scottish Highlands environment. And that person might need more tools in their box. We would love to treat it all with lifestyle and be able to, I'm a massive advocate for lifestyle medicine, to be able to look at that person's lifestyle and say, what's the first thing that we can do? And it's the same with, say, asthma or diabetes. You look at the lifestyle first. What things can we introduce into someone's life who might have ADHD, or certainly having this characteristics of being burnt out and seeking comfort in food or alcohol. Lifestyle medicine, if you look at it, I've always gone about my 6 pillars, looking after your sleep, looking after your stress, whether that's through exercise or meditation, looking after nutrition, not putting lots of rubbish into your system. And we know that, I don't know your take on it, but we have a strong brain-gut axis. Eat rubbish, you feel a bit rubbish. But also things like your social connectedness, having a good social network. And again, toxic substances. I think about alcohol, I think about drugs. Obviously, patients who have these traits of ADHD and who are using things like alcohol we know is it's a depressant. It increases your anxiety. So the knock-on effects. So again, lots of things you can do with lifestyle before even getting to the medication side of things.
Our lifestyle nowadays is very different from, say, 50 years ago, our parents' generation. And this kind of links back to that. Why is there a rise of ADHD? Perhaps maybe the genetic predisposition is always there, but because you now add so much stress into our lives, it demands a
huge environmental triggers.
Oh, absolutely. And you have to be at this place all the time. Whereas, in the century past, 50 years ago, perhaps kids can get themselves to places and you don't have to be this driver. And I see a lot of pathological demand avoidance, in children because they're being forced to respond in time, in a short amount of time. So coming back to your question, what role does, lifestyle play in these people with possible ADHD symptoms? I actually think that's the first and foremost important thing, because before you even look at sort of medication intervention, because if you address the 6 pillars, of health and actively at that particular stages in life when, cracks are showing, to attend to your own health, to manage your busyness and actually really question yourself, do I have to take all of this on to myself? Could I outsource that? Could I give myself an easier time? And then look at actively what are the strategies that we can use to be more organized based on our own current lifestyle. And there's ADHD coaches that could help to advise that. Psychologists couldn't do that, or you could even just sit down and look at your own life. I think anyone and everyone can benefit from that, whether you actually have an ADHD diagnosis. But if you have ADHD diagnosis or suspected ADHD diagnosis, that's even more important, because we all know that any kind of medication, number one, is not the holy grail. There's a lot of hype out there in terms of medication for treatment for ADHD, but there's actually also a lot of risks, in particular if you have comorbid bipolar, ASD, other conditions. It will actually make things worse. It might even send you into a psychosis. I've seen it lots of times. Lifestyle will never give you a side effect, only benefits. And also, I have also seen people who temporarily use ADHD medication to get through the burnout in addition with lifestyle. And then they find, well, I'm actually okay now. So then they don't need it long term. So that's also another good evidence to show that perhaps if they can, at the outset, really address the lifestyle stuff, they may never need to go to the medication part, which is very often cost-free, brings your quality of life a lot better, and the people around you a lot happier as well.
Thank you. We're going to wrap up now. I have one last burning question. I think it's probably just about that whole ADHD in women. Why do you think women get missed in terms of diagnosis? I'm thinking about our young adolescents.
Yeah.
Why do you think, and I put my hand up as a GP, I want to be able to have my spidey senses out there. So why do you think it's been missed in that sort of cohort, our teenage girls, our sort of young 20s, and I see it at the universities, it has been missed, and it's not until sometimes a little bit later they could have done better at school. They could have. Why do you think we're missing it?
I think as a child psychiatrist, I see this all the time. I find ADHD that's expressed in women or young, or the female variant, tend to be more inattentive, and often girls socialized to be compliant, to follow the rules. So they're not going to get picked up in school, particularly early on, because they're not like the boys who are hyperactive and who's making themselves a bit of a nuisance in class. And number one, they don't get picked up. And also you'll find that there are stages where kids tend to get picked up and not. Stage one is when they attach themselves to primary school. And usually that's when they have ADHD more hyperactive type, then they get picked up because they don't do well in that structured environment. But some girls really do well in that structured environment. And then as you get into high school, that's another stage where you may get diagnosed or you may not, because the structure is less and the demand is more. But if you're quite intelligent and again, very compliant, you actually thrive really well in that environment. So you get by. And then you get into university. Some people, that's when the cracks really show, because they can't get assignments done, because you now have very long time and no one structured to remind you. So that's where university, a lot of really high functioning, smart girls start to go, without the structure of high school and some of that spoon feeding, I'm not doing so well anymore. And I'm struggling with my first job, my first relationship, and living away from home. So no one's looking after me. So my life is literally falling apart. And that's when they show themselves. Or if you get through all of that, the next stage is when you're in your late 30s and 40s, when you wear so many hats, as we talk about.
Big career, big family, lots of responsibilities. So it is out there, and I think it's probably the awareness is the thing that we want to bring from today's talk. Also, that a diagnosis or the traits of ADHD does not necessarily always equate to medication. There are lifestyle aspects we want to explore, but perhaps just that raising the awareness so that we can have it in the back of our minds when we see these traits in women coming into our surgeries or in our lives. When you see the burnout, when you see the anxiety, and when you see that sort of comfort eating and sort of pleasure seeking from dopamine sort of short responses. Alice, thank you so much. Thank you so much for having that big chat with us and bringing us your excellent expertise. I'll put a couple of references for our listeners to have a little look through as well, to have a little bit read about. And Alice, thank you so much. Thank you very much.
Thank you.